Hello, and welcome to the third episode in this series of podcasts on peripheral vascular disease. In this podcast, I'm going to discuss disorders of the venous drainage of the leg. In order to understand the disorders which affect venous drainage in the lower limb, it is first useful to consider the anatomy of the veins which drain the leg. The venous drainage of the leg consists of the deep venous system, which comprises the popliteal vein, which drains into the femoral vein. As well as the deep venous system, there is the superficial venous system, which comprises the small saphenous vein, which runs laterally up the leg and drains into the popliteal vein at the saphenopopliteal junction, and the great saphenous vein, which runs up the medial side of the leg and the thigh and drains into the femoral vein via the saphenofemoral junction. In addition to the superficial and deep veins, there are several perforating branches which connect the two systems at various levels within the leg. Efficient venous drainage depends on the presence of valves within the veins which prevent backflow of blood back down the leg due to the action of gravity. Blood flow through the veins is driven by the calf muscle pump. As the muscles of the calf contract, they compress on the veins in the deep venous system of the leg, causing blood to be expelled up towards the heart. The valves within the veins then prevent backflow of blood back down the leg, and as the calf muscles relax, reduced pressure within the veins draws more blood from the superficial venous system into the deep venous system, thus maintaining blood flow through the veins back to the heart. Broadly speaking, it is the failure of valves within the veins to prevent backflow of blood which results in disease associated with impaired venous drainage of the lower limb. The nature of the symptoms experienced by the patient depend on whether it is predominantly the superficial or the deep venous system which is affected, although in many patients there is failure of adequate drainage in both venous systems. Valvular incompetence within the superficial veins results in varicose veins. The patient will complain of abnormally distended and tortuous veins in the leg, and the distribution of these veins will depend on exactly which vein is affected. The patient may also complain of aching in the legs and swelling of the ankles, especially after long periods of standing. Complications of varicose veins include hemorrhage following trauma and phlebitis, which is characterized by inflammation in the skin and tissue surrounding the varicose vein, and this may subsequently become infected. Initial management of varicose veins is conservative and involves simple measures such as elevating the leg and applying compression using a pressure bandage or graded compression stockings in order to improve blood flow through the veins back to the heart. If the patient experiences severe symptoms or complications such as hemorrhage or recurrent phlebitis, then further management may include sclerotherapy, which involves the injection of a sclerosing substance around the varicose vein, which causes localized fibrosis and regression of the vein. Further management may include surgical stripping of the affected veins. The underlying etiology of varicose veins is not clearly defined, and in the majority of cases there is no clear defined cause. However, varicose veins occur more often in women than men and may also occur during pregnancy as a result of pressure on the inferior vena cava by the gravid uterus. They may also occur secondary to deep venous insufficiency due to back pressure on the superficial venous valves, which leads to valvular incompetence. Furthermore, there are congenital syndromes which may result in the formation of varicose veins, such as the Kippel-Trenaunay Syndrome, which is characterized by the presence of varicose veins and extensive hemangiomas or port wine stains over the legs. Moving on to deep venous insufficiency. This results due to venous hypertension, which puts back pressure on the valves within the deep veins, resulting in valvular incompetence. It may also occur as a result of congenital absence of valves within the veins and secondary to deep vein thrombosis, as a thrombus within a deep vein may disrupt the valves within the vein and render them incompetent following resolution of the thrombosis. Valvular incompetence may also occur as a result of arteriovenous fistula due to back pressure on the valves as a result of high pressure arterial blood flowing into the venous system. The presenting symptoms of deep venous insufficiency include swelling of the legs, dark pigmentation of the skin as a result of hemosiderin deposition, venous eczema, which may cause pruritus, and lipodermatosclerosis. This is characterized by a fibrotic reaction which occurs in the subcutaneous tissue in the lower leg, resulting in the characteristic appearance of the inverted champagne bottle. As mentioned earlier, there may also be varicose veins which occur secondarily to perforator incompetence. Finally, there may be venous ulceration of the lower leg. In contrast to arteriopathic ulcers, venous ulcers tend to occur on the medial side of the leg in the gaiter area. They tend to have a ragged edge, and there may be a white rim around the ulcer where scarring has occurred, and this is known as atrophy blanche. Under rare circumstances, malignant change in the edges of the ulcer can result in a squamous cell carcinoma forming a Marjolins ulcer. Specific tests and investigations for venous disease include performing a tourniquet test. The tourniquet test is used in order to determine the level of valvular incompetence within a leg, which results in the formation of superficial varicose veins. The patient's leg is lifted up in order to drain the veins of the leg, and a tourniquet is applied and tightened around the upper thigh. The patient is then allowed to stand, and the superficial veins in the leg are observed to see whether or not they refill. If the veins do not refill, this indicates that the valvular incompetence which has caused the varicose veins is either present at the saphenofemoral junction or within the varicose vein itself. If the vein refills despite having applied the tourniquet, this suggests that valvular incompetence is present within the perforating veins which connect the deep venous system to the superficial system. The tourniquet may then be applied at progressively lower levels down the leg in order to establish the location at which perforator incompetence occurs. Further investigation may include duplex scanning, which may be used to assess the level of valvular incompetence within the venous system and to look for reflux at the saphenofemoral and saphenopopliteal junctions, as well as at the junctions of the perforating veins between the deep venous system and the superficial venous system. As for varicose veins, conservative management forms the mainstay of treatment for deep venous insufficiency and includes simple measures such as elevating the leg and applying compression using compression bandages or graded compression stockings. Care should be taken when using compression stockings or compression bandages to ensure that there isn't any concurrent peripheral arterial disease within the affected limb. For this reason, it is important to measure the ankle brachial pressure index to check for any ischemia within the limb. So to summarize, in this podcast I have discussed the anatomy of the venous drainage of the leg, which is divided into the deep venous system and the superficial venous system, which are connected to each other by perforating branches. I have also discussed the signs and symptoms of disorders of venous drainage, which include varicose veins and deep venous insufficiency. I have discussed the role of conservative management in treating patients with venous disease, including the role of elevation and compression of the affected leg, and more specifically, the use of sclerotherapy and varicose vein stripping for varicose veins. So this concludes this episode on peripheral venous disease. Thank you for listening.